So I think her topic is qualitative and quantitative analysis of pediatric cataracts using optical coherence tomography.
Thank
So
you so much.
Dr. Savleen Kaur from PGI.
I had a simultaneous session, so thank you so much for accommodating. So I'll be talking about anterior segment OCT, and I will be using the term ASOCT whenever I talk about the same. I have no financial interest. Okay. So pediatric cataracts are very heterogeneous, and it is imperative to obtain a complete anterior segment examination before we take up the child for surgery. In adults, we traditionally use the slit lamp, and children are often uncooperative for a slit lamp examination. So and often in complete preoperative examination is possible only under anesthesia. So we wanted to see whether we can use the ASOCT as a preoperative tool for assessing pediatric cataracts. This was a prospective observational case series. After obtaining ethical clearance, it was done at the Advanced Eye Center, PGI Chandigarh. We recruited children who were birthed to 8 years of age, and we excluded children who had significant corneal opacities or where we could not obtain a clear ASOCT scan. All patients underwent a detailed ophthalmic examination, including the biometry, as in a routine case of pediatric cataract. In addition, all children were subjected to the ASOCT imaging in office. The anterior segment optical coherence tomography was done a week prior to the surgery. In case the child was too young to sit on the slit lamp, the child was straddled in a butterfly position. All the examination was done under dilatation with tropicamide and phenylephrine. And in real time, this was the swept source ASOCT that we used, and it took about 3 seconds. So most of the children which were younger had to be straddled in butterfly position to get good scans. We wanted to see whether the morphology of the cataract, the status of the anterior and the posterior capsule that we see on the ASOCT matched with the intraoperative findings. We also wanted to quantify the opalescence in cases of pediatric cataractus lens and investigate what clinically important information the ASOCT could provide us. The study was done in 2 phases because of the COVID pandemic. We ended up recruiting 80 eyes of 50 pediatric cataracts, ranging from 3 months to 8 years of age. We had all sorts of etiologies, but congenital cataract constituted the major one. A normal ASOCT lens scan looks something like this, with a hyper-reflective anterior and a posterior capsule, and the nucleus of the lens also hyper-reflective, with the cortex showing some hyporeflectivity. We saw all sorts of morphologies that we could find on the ASOCT, the anterior subcapsular cataract giving us a hyperreflectivity along the anterior capsule, the zonular cataract with riders, then we could make out anterior pyramidal cataracts, posterior subcapsular cataracts could be seen, and the posterior bowing of the lens capsule in cases of posterior lenticonus could also be appreciated. A reduced anterior posterior depth could be seen in cases of membranous cataracts. We could image total cataracts, partially absorbed cataracts, subtotal cataracts, and often anterior capsular rupture in cases the cornea was clear. It was very beneficial to do the ASOCT in cases of white cataracts because a white cataract was labeled as white on the slit lamp, and on the ASOCT we could appreciate the anterior and the posterior capsular fibrosis, which necessitated the use of a vitrector at the time of cataract surgery. In total cataracts, in 2 cases, we could map the posterior capsular defect. As you see, the scan is moving from the nasal to the temporal side. The site and the area of dehiscence of the posterior capsule could be seen, and we could see the herniation of contents into the vitreous in cases where the cataract was white. When we compared the morphology on the ASOCT and the intraoperative findings, we saw that it matched to the extent of 94%, and we could get an accurate information about the integrity of the anterior and posterior capsule also in 97%. The second part of the study, we extrapolated the images into an external images software. We extrapolated the lens and the nucleus and calculated the pixel density in these patients. So this density was graded on 0 to 255, and we saw that a peculiar type of cataract gave us a peculiar type of intensity. So if you know the intensity, you can kind of tell which kind of cataract the child will have, because a typical zonular would give us a more nuclear and a lesser lens density, and so on. We also got a positive correlation with higher nuclear densities and lower visual acuities. So our study does have limitations because we do not have a control group. It would be kind of unethical to know the ASOCT findings and not tell the surgeon about it. And the availability as a technology of the ASOCT is also limited to maybe tertiary or research centers. We cannot replace a complete examination by a sophisticated instrument, so a gold standard is still a clinical examination. Nevertheless, our study is the first to report the use of ASOCT to study the pediatric lens in vivo. It is a valuable tool to know the lens morphology and the capsule without the need for anesthesia, and the findings correlate well with the clinical parameters. We also propose an objective assessment of lens opacification. In a country like ours, where there is no concept of neonatal screening, maybe this quantitative analysis can help us in longitudinal follow-up of patients. And also there might be scenarios like diabetic cataracts or steroid-induced cataracts where you need a follow-up and a quantification might come in handy. So it helps us in delineating the morphology of the lens and the capsule, and it can reduce our intraoperative surprises. I would like to acknowledge my team and Dr. Jagatram for a legacy of pediatric cataracts that he has left us. Thank you so much.
Thank you, Dr. SAVLEEN KAUR. I'd like to know whether the OCT findings always correlated with your surgical findings, that the posterior capsular integrity always does it correlate with the ASOCT findings?
Thank you for that question, ma'am. In our study, we found it to correlate in 97%. So where you have a bad cornea, there the ASOCT will not come into use because it will not be able to go back. It's an optical method, so it has a disadvantage against, say, the ultrasound. But in case you have a clear cornea, then the accuracy is 97%.
Have you compared it with B-scan findings?
Ma'am, I am doing the study. I mean, this study is not talking about comparison with the ultrasound, but when we do, because the swept source has more penetration, delineation of the capsule better than sometimes even the ultrasound, because if you indent too much, sometimes you might get it. But yes, again, in patients where you have bad corneas, the ultrasound is way better than the ASOCT. That's part of the unpublished.
So you could do this in all congenital cataracts or selective?
So my indications now after doing the study are white cataracts, because in white cataracts it gives us a lot of information. In children who are developmental delayed, sometimes they don't sit at the slit lamp and they don't show, and a 3-second scan can give you a lot of information. And also cases where I'm trying to follow up ROP cataracts, as I said, diabetic and steroid induced are my indications of doing ASOCT, and that would be adding information.
Use a specula?
Ma'am, I have not actually, because because that makes the baby, it makes it into a contact method, so then the whole point is lost. So I have not used the speculum, but you can. We were doing a study on ROP babies, so where we did use the speculum to get better scans.
So only if we suspect capsular pathology is if
Yes, sir.
quite opaque, maybe in those cases might
Yes, sir.
add to additional information.
Yes, wherever we suspect a capsular pathology, it will be of immense use. Yes.
97 is a good number.
In total cataracts, if you're suspecting a posterior lenticonus, but that can even be caught by the B scan.
Yes, ma'am. That can be,
So,
we can get by B scan.
B-scan
Also, just
also,
that
huh?
B scan requires, in child, you have to straddle it. It's a contact method. Again, you want to do it in the OR. You want to do it just before the surgery. Then you have, some people do not like to do the ultrasound at the time of surgery. They want to schedule it. So another EUA visit for the child, I think, can be avoided if you just do a non-contact scan like the ASOCT.
Thank you.
Okay.
Thank you so much.